Just close all my tabs, like maybe.
Is Facebook still open, or is it?
I think it might be. I've got lots of windows and tabs.
Oh God, how do you do this? Sorry. Okay. Now I just need to make sure that that works. Okay. So I just have to check if there's sound, then we're all good to go.
Preferably wasn't sound, to be honest. Really good.
Hello? Where are they? Where my laptop?
Okay. Wait, Jen, I think there's sound. I think there is sound, yeah.
You guys are ready.
Where is it?
Oh, dude, that's fine.
Yeah. Okay.
Sweet. Okay, good. Okay, thanks so much.
Awesome. Start whenever. Thanks for coming, guys. This is Sabrina. She's going to go through neurology with you. Be nice to her. Yeah. Oh, do you want to post this on? I'll post it onto your Facebook now.
Thanks, Jen. Where are you? So hey guys, thanks so much for coming. So I'll be trying to go through neurology today, sort of the basics of what you need to know, and scattered throughout you have a few questions just to keep you awake. But in the meantime, if you have any questions, do let me know. So I'm currently a 4th year student at Monash doing my pediatric rotation, which is really good. So you guys should look forward to that next year. Alrighty. So what we'll be going over today is mainly vascular disorders. Then we'll go through a bit of neuroanatomy under the vascular disorders, and then some spinal tract problems, and then some headaches, and then some infection inflammation. Just some general advice, start practicing OSCEs now if you haven't. It's really different type of OSCE compared to 2nd year in terms of the amount of time you have and the types of things they'll be expecting. So you've got not just your basic history or just your basic examination, there'll be your investigations and management tacked on to the end. So I think it's really good to know your main starred conditions on your matrix and just know one sentence each on how to explain management, investigation, lifestyle, and also medication-wise. Also, some practice OSCEs related to neuro would include your basic collapse or your syncope, maybe a coma history, someone who's presented unconscious to ED, your headache history, and also consenting lumbar puncture. I think it's fair game if they give you a targeted cranial nerve examination, such as your eye, so it could be 2, 3, 4, 6, or it could be your other cranial nerves as well. That's what we had last year. And in release papers that faculty does put out, make sure you go through the EMQ options at the end, not just know which one's the right answer, but I feel that if you know one line each about what options are correlating to which condition, that also really helps because those can be potential answers in other papers too. Cool. So moving on to vascular conditions first. So in terms of your vascular conditions of strokes, you can break them down to your ischemic and hemorrhagic strokes. And by far, your most common one will be your ischemic strokes. And under your ischemic strokes, you've got your thrombotic and your embolic strokes. Thrombus would mean a clot that's essentially arisen from the artery itself, or an embolus could be from anywhere else in part of the body, say like from your internal carotid slicking up to your brain, or from your heart, say your mitral valve and infected endocarditis or something, or a blood clot from an MI. In terms of your hemorrhagic stroke, by far your most common one will be your subarachnoid hemorrhage and your aneurysms. So some risk factors under strokes, I realize that's sort of a large group, but a lot of them are corresponding to your metabolic syndromes of hyperlipidemia, age more than 65, smoking, alcohol, all of your SNAPs, obesity, having a past stroke or past TIA, having a heart disease because that puts you more prone to having an MI. Having MI puts you more prone to having an embolic event. Having hypertension because that's a huge risk factor for your arachnoid hemorrhages and your aneurysm formations. Hyperlipidemia, peripheral vascular disease, and diabetes. Righty, so moving on to your general presentations. So stroke is generally a sudden onset of non-convulsive focal neurological deficit. So it's a sudden onset. And it can present really differently depending on what part of the brain it affects. So it can be some numbness, it can be some impaired movement or speech, it can be some visual disturbance. And I guess the one that the community is most aware of would be your FAST, so your face, your arms, your speech, time. So moving on to your characteristics, they generally have to last for more than 24 hours. If it's less than 24 hours, that would be your transient ischemic attacks, your TIAs, and doesn't have any long-lasting effects. But it does put you at risk for future strokes. So a quick recap on your anatomy. So going through your lobes really quickly, you've got your frontal lobes at the front. So that's in charge of your motor function, your language production, and also your memory and higher cognition. So your personality, your judgment, your olfactory senses. And just remember that your Broca's area is also in the frontal lobe because that's part of your motor production. So your speech for Broca's. In terms of your parietal lobe here, you've got your memory, your language, your auditory, and also your sensory. So here behind at the postcentral gyrus, you've got your somatosensory area, and at the front, at the precentral gyrus, you've got your motor. So moving on now to your temporal. This is your, oh sorry, I got that mixed up. So temporal is your memory and your language and your comprehension, whereas your parietal lobe is generally your somatosensory and your spatial processing. Moving on to your occipital lobe, this is where you have your visual processing and visual interpretation too. Okay, so moving on to your homunculus, this should be familiar from back in second year. You've got your small person essentially dangling from the inside of your brain with the leg in the inside of the brain, and you've got your arms on the outside and then your face. So this also corresponds quite nicely to your blood supply to the brain. So with your posterior cerebral artery, that's at the most deep of very deep down here and also down to your occipital lobe. And then you've got your anterior cerebral artery corresponding to most of your legs. So the sensory part of your leg as well as the motor part of your leg. In terms of your middle cerebral artery, that's mostly your face and your arms. So that's where your FAST comes from. So going over your stroke of Willis very quickly, at the junctions here of your anterior communicating artery and also your posterior communicating, because of the junctional areas, that's where you're most prone to get aneurysms, because that's where all of the high blood flow of hypertension hits those bifurcations, and that weakens the walls of the vessels, and then that eventually forms an aneurysm, and the aneurysm can burst. So just a cross section again showing the blood supply of your ACA all in yellow. So the inside, and also the front of your frontal lobe, and bits of your frontal lobe at the back too. In terms of your MCA, you've got the red part, so that's corresponding to your temporal lobes and some of your parietal lobes, and then your occipital going back to your PCA down here. Okay. This is just what I just said in words, and just go through that in your own time. So just there for your own reference. Okay, so moving on to ACA, these are quite busy slides, but hopefully going through them won't be too bad. So in terms of your ACA, as I said before, it supplies your medial motor cortex, that's the yellow part, and then that also corresponds to the legs of your homunculus over here. You also got your medial sensory cortex, which also corresponds to the legs of the homunculus, so contralateral lower limb sensory loss. And you also have your prefrontal cortex, which is your personality and your judgment. So if you have an ACA stroke, it can give you lower limb contralateral sensory motor weakness and loss, as well as some changes to your personality. Alrighty, so moving on to your MCA. Your MCA is quite it's quite a large artery and it supplies a lot of your brain. So you can actually break it down to your superficial parts and also your deep parts. So in terms of your superficial parts, you can break them down into your superior division and your inferior division. And your deep parts can be your deep branches. So going to your superior division, first of all, that corresponds to your face and your arms of your homunculus. So that corresponds to your contralateral motor and sensory cortex. And then you've also got the inferior branch, which is sort of down here. As you can see, the inferior branch sort of corresponds to your temporal lobes, your temporal parietal lobes. So as a result, can affect your dominant parts of your lobe. So if it's your dominant lobe, it can affect your Broca's and Wernicke's area, and they can give you aphasia. But if it's non-dominant, they can also give you things such as neglect, like partial neglect. So if it affects your temporal parietal visual tracts, that can also affect your vision. So with the MCA stroke, it can give you homonymous hemianopia. And going down here to your deep parts of your MCA, that supplies your internal capsule. So if you can think about your tracts going up through your legs, up through your spinal cord, up through your spinocerebellar tract, your brainstem, and then it goes through something called your internal capsule, where like all of your motor and sensory tracts run through. So it's a very fine area. So any small damage to the area can give you total loss of, say, your whole motor sense or your whole sensory sense. So, and then that branches out again to your sensory cortex afterwards. So if you want to correspond these cortices to your syndromes, your motor and your sensory correspond to your contralateral upper limb facial weakness and sensory loss. If you go through your inferior MCA supply, this corresponds to your Broca's and Wernicke's non-fluent and fluent aphasia. So one way I remember the difference between Broca's and Wernicke's is that Broca's is broken, so that means that you have broken speech essentially. So you understand everything, but you can't really express it. So broken speech for Broca's. So Wernicke's is wordy, so in the sense that you can't really understand things, but you can say things okay. So you just sort of have like a word salad sort of presentation. So that's in your temporal lobe. So your patient can speak fluently, but the words don't really make sense. So this is how you can break up your MCA strokes. And as I mentioned before, with your internal capsule, it can give you your completed one-side motory or sensory loss. Because this also corresponds to your visual tracts, this can also give you some contralateral homonymous hemianopia. Just going back to your MCA inferior strokes, that also affects your temporal parietal visual tracts, and this can give you homonymous hemianopia. So what this will look like, So what this looks like is you have one side of your visual field lost, but because your MCA supplies a lot, essentially the whole tract, it's not macular sparing. So macula is the central part of your vision, which actually is where all of your rods are most concentrated, and it's not spared. So you actually lose your vision completely on one side. Yeah?
Sorry, with the branches, when you say one-sided motor or sensory,
Yeah.
is it generally like just one or the other? Like,
Yeah, so it's a good question. So as I mentioned before, it's a really small area, and any infarct can impact it a lot. So it can be complete motor, it can be complete sensory, it can also be a mixed motor sensory. But the thing is, it's just completely one side of the body. So it doesn't really correspond to how your homunculus anymore, because the homunculus is very spread out, whereas this is a very small area. Yeah. Okay. So moving on to your PCA now. So your PCA supplies essentially your occipital lobe. So in your occipital lobe, you've got your visual cortex, and you've also got your PCA supplying your corpus callosum and your thalamus. So going to the visual cortex, first of all, this gives you contralateral homonymous hemianopia, as we explained before. But the difference here is that it's macular sparing, because the macula is a really important part of your vision. You definitely need things to see. You need to see things. So you've got your MCA still supplying some parts through contralateral supply. So that's why it's macular sparing. You also get cortical blindness, which is a possibility where you don't see anything. The patient says they can't see anything, but your pupillary reflexes are still intact. You also have some damage to your corpus callosum, which is a potential. As we can see, PCA has a deep branch down here, very deep in the brain, close to the corpus callosum. So you can have this thing called alexia. So it's a bit like dyslexia, where you can't read properly, but in this case, you can't read at all. You can't really comprehend, but you can still write. In terms of thalamus, you also have your sensory pathways going through the thalamus. You can also have some contralateral hemisensory loss or pain. And because the PCA is also quite close in proximity to cranial nerve 3, you can have a cranial nerve 3 palsy, having a down and out vision on that side ipsilaterally. Okay, so this is sort of what it looks like to be macular sparing, whereas if the whole half of the semicircle was colored in, that would be non-macular sparing. Okay. So other strokes that you might have would be a brainstem stroke. So brainstem strokes are by far the most debilitating and the hardest to rehabilitate because you've got so many things and so many decussations happening at your brainstem. So you can actually have quadriplegia, where all four limbs can't move. You can have visual disturbances because of all of your cranial nerves exiting through your pons and around that area. So that can affect your vision. And you can also have this thing called a locked-in syndrome, where the patient is fully cognitively aware, but they actually can't move their limbs. The only thing that they can move is probably their eyes, and that's only a very small part. So that's actually has quite a poor prognosis, and it's quite scary. Other types of strokes that we should probably talk about would be a lacuna stroke. So lacuna stroke is sort of your subcortical infarcts. So what I was talking about before with your ACA, MCA, PCA, those are all cortical infarcts where it's at the top of your brain, where everything is all quite spread out. Whereas your subcortical infarcts are closer to your basal ganglia, your internal capsule, your thalamus. So they're less well defined as your cortex. So because of this, you can have a quite different presentations, such as pure motor, pure sensory, or mixed motor sensory presentation. And these involves your perforating arteries. So they don't really have names, just very thin arteries that supply your internal capsule. And you can also get some ataxia, hemiparesis as well with your lacuna strokes. Just keep in mind that your lacuna strokes don't affect your cognition or your consciousness because that's all happening in your cortex in the front of your brain. Yeah. Oh yeah, so sort of the MCA is, so all of your blood vessels sort of come off through your circumvellus. And because the MCA supplies a large part of it, the deep branches, I guess the most deep branches of the MCA can be broken down into your lacuna arteries. Yeah, so it's just more sort of like reinforcing like how lacuna arteries strokes can present differently to your cortical strokes.
It's the same thing.
Yeah, essentially. Yeah, it's sort of like a subset of MCA. Yeah, cool. So just going over stroke very quickly. So stroke is essentially rapid onset of neurological deficit, and that occurs for more than 24 hours. Your ischemic strokes are by far your most common at 80%, and your hemorrhagic strokes are less common, but they have a poor prognosis. So as I said before, your ischemic strokes can be through a clot, so it can be through a thrombus or embolus, and it can also come off through your vessel walls, such as atherosclerosis plaque breaking off. For your hemorrhagic strokes, it can be a subarachnoid where you have a berry aneurysm commonly at your circumvellus, and that can burst. And you can also have intracerebral hemorrhagic causes, such as being a warfarin and hitting your head, or having weak vessels, or having hypertension. In terms of your investigations, you probably want to take their blood pressure. It's really important to control their blood pressure at this point in time. You also want to take maybe a bedside ECG to check if they have AF causing such like a thrombotic event. In terms of bloods, you want to check FPE, BSL, UC, coags, and troponins. You maybe group and hold too if they have to go to surgery very urgently. For imaging, your first line is always a non-contrast CT. Non-contrast CT is best for your hemorrhagic strokes because for a very acute bleed, the bleeding will be a white color, and that can be picked up very, very early on. However, if your bleeding is dark and it's been quite chronic, you might not be able to pick it up in a non-contrast CT. So as a result, you might need to go to an MRI. An MRI in this case is best for ischemic strokes. In terms of a non-contrast CT, if it's negative and you still think it's a hemorrhagic stroke, you can consider doing a lumbar puncture. Doing a lumbar puncture is important because you can rule in a hemorrhagic stroke, such as a subarachnoid with xanthochromia. So if you take subsequent CSF samples, you should have quite a yellow sample first of all, which is your xanthochromia, then a less yellow sample, and then a less yellow sample. So the yellow color is due to your bilirubin breakdown from your red blood cells, and that gives you that yellow pigment. And it takes a few hours for that to break down. So this is a good time to take CSF if your non-contrast CT shows up negative. Okay, so and just one more thing with your xanthochromia, you might get some blood early on, but that blood probably won't show that it's a subarachnoid because that blood's probably from the puncture site of going in to get that sample. Okay, so moving on to your management, you probably want to do basic life support first of all to make sure the patient is still alive and well, going through your ABCs and CT brain. After that, you want to manage, so by then you can tell whether it's an ischemic or hemorrhagic stroke. Very important to distinguish because your management lines are very, very different and you might end up killing the patient if you make the wrong decision and give them the wrong treatment. So for ischemic stroke, you can give them tissue plasminogen, which is essentially a clot buster. So you can give it to them within 4.5 hours. There are some contraindications where you don't give it, such as if it's an intracerebral hemorrhage, they've got clotting disorders, they've got recent arterial invasive procedures. However, generally ischemic, this clot buster drug can be given within 4.5 hours. After that, you want to manage the aspirin and the statins to prevent another clot from forming and prevent DVTs. And you want to maintain their blood pressure because essentially you've got a blockage in your brain. So you want to keep the blood pressure up to maintain flow to that area of brain so it doesn't go necrosed and die off. In terms of your hemorrhagic management, you want, if they're anticoagulated, you want to reverse your anticoagulation, and you want to decrease the blood pressure and decrease the cerebral pressure. So in this case, you can tilt their bed up to 30 degrees head tilt. You can take regular blood pressure readings, and you want to stop their seizures as well. Okay, so long-term complications of strokes. If you have one stroke, you're more likely to have another stroke, and generally you have motor weakness, and you might have communication impairment too. In terms of your mood and cognition problems, that can also be attributed directly to the stroke itself, maybe if it affects your frontal lobe, but also, I guess, having a chronic condition and not doing things that you can do in the past, that can also give you major lifestyle changes, which you might not be prepared for. So it's really important to do counseling and also making sure that that people go into rehab as quickly as possible after they're medically stable to make sure that they can get better as soon as possible. Dysphagia is a really important thing in old people that you might see in rehab because if you have strokes, it might affect your swallowing muscles. It can give you some palsies there, and then this can put them at increased risk of like aspiration pneumonia and further risk of other conditions too. Okay, so just a few questions. So Mrs. S has a weak face, arm, leg, and also homonymous hemianopia. She is not communicating with her family. Where do you think her stroke is going to be? Yeah, good. So MCA territory, nice. So your MCA correlates to your arms, facing your arms. So I guess the leg is a bit of a trick because it can also be another part of the brain. It's more so associated with your ACA, but I guess the overall picture of the homonymous hemianopia and the aphasia points more to an MCA picture. Okay. Mrs. V has weak face, arm, and leg and homonymous hemianopia. She's confused and she thinks that her left arm belongs to someone else. Picture, she draws this. Where do you think her stroke is going to be? Yeah, MCA, wonderful. So it is an MCA stroke, but I was sort of going, I guess they could break down the question to be an MCA on the dominant side or an MCA on the non-dominant side. So in this case, is it a dominant or non-dominant side? Non-dominant, yeah. So she's got neglect. So neglect can be pretty interesting. It's not just your drawing. It can also be like shaving. Someone might just shave one side of his face, but not the other side. Like eating as well. They might just ignore all of the food on one side of their plate as well. So neglect is pretty interesting. Okay. So Mr. G, after suffering a stroke, has weak arm, leg, and face. Where's the stroke most likely going to be? Yep, sort of, but he's got weak arm, leg, and face. So it's like, yeah, nice. So it's more the internal capsule. So I guess when they say MC, they're more referring to your cortical area, but more your deep arteries, your internal capsule. Nice. Okay. So 45-year-old, poorly controlled, hypertensive woman presents in the emergency department with a stroke. Further testing after admission shows marked fluent dysphagia, jargon speech, and a right homonymous hemianopia. Where do you think her stroke is? Yeah, nice. And why do you say that? Yeah. Nice. Yeah, cool, really good. And I guess they can also, if they wanted to, they could also break the question up into quadrantinopias, inferior or superior ones. So they can also correlate to your parietal or temporal lobes too. Good. And as you said really nicely, it's in your parietal temporal area, your Wernicke's area. And it also gives you a homonymous hemianopia, which is non-macular sparing. Okay, so 62-year-old male was sent urgently to ED after his family members witnessed him becoming weak at the knees and crumpling to the floor. On arrival to ED, a cranial nerve 3 palsy of his left eye is noted. It could be, I guess, ASA, you probably just have you might get weakness on one side of your leg. Probably wouldn't give you such a debilitating collapse. What about the cranial nerve 3 palsy? What part of your brain is your cranial nerves? Yeah, so more so the vertebral basilar territory. Maybe it's not such a great question because I wrote it, but I was trying to go through like a very drop attack sort of picture. So drop attack is sort of a buzzword for your vertebral basilar territory stroke because it's very debilitating. So it sort of like affects all of your limbs. And also you've got your cranial nerve 3 palsy, which is your cranial nerves corresponding to all of your arteries going in that area. Okay, so just going through pathology of brain infarcts really quickly, because I know that you have a path exam at the end of the year. So I'm not too sure if path, this might come up, but maybe. So in terms of your pathology for brain infarcts, it's probably good to know the gross macroscopic picture at each time. So less than 24 hours, what do you think an ischemic stroke will show? Yeah, so nothing. So it shows nothing. Very good. So at 1 to 3 days, if you've got lack of blood supply to an area, what do you think the tissue will look like? Yeah, I'd say so. So it starts to get a bit gross and gunky. So no blood's going in, no blood's going out. So the picture that I have here is sort of like a soft, swollen, pale, edematous sort of picture. And you sort of lose your gray and white differentiation between the cortices at the top too. At 3 to 5 days, you probably will have some of your coagulative picture coming in. So you've got all of your inflammatory white cells coming in, your macrophages eating up the necrosed tissue. And remember, in your brain, it's the only part of the whole body which has liquefactive necrosis, whereas most parts of your body has coagulative. So it sort of essentially liquefies the brain. And you might have some gliosis, so some glial cells proliferating. And long term, you'll have a fluid-filled cystic cavity because it's liquefactive. Okay, so around how many days would you say this infarct is? So you sort of got your nice white bits of brain here, some nice gray bits here, and here you've got no white or gray bits. It's just like this clump. So I'll say probably maybe 1 to 3 days. Because it looks a bit swollen. It doesn't look pale, but it might be because of the cross-section itself. But you've got the loss of your gray-white area, and you've also got some edema. So I'd say probably 1 to 5 days, or like probably a week. Yeah. Okay. What about this bit?
Is it more than a week because now there's like a cystic cavity, or is it just really
Yeah, no, I think you're right. I think you're both right in both senses. So it looks like a cyst because it's fluid filled. So I'd say it's liquefactive. So it's probably, as you said, liquefactive necrosis with cystic space. Just with the brain itself, because it's like very soft. And if you have liquefactive necrosis in a large part of your brain, you might actually get some midline shift. So that can be quite debilitating as well, because you've got no brain on one side and some brain on the side, so that pushes it over to that side. Alrighty, so fluid-filled cystic cavity. Okay, so moving on to bleeds quickly. So bleeds, in terms of going back to your second year anatomy again, you've got the layers of your scalp. So with your scalp, you've got, quite nicely, your scalp corresponds to the layers of your scalp. So you've got your skin, your connective tissue, your aponeurosis here, and you've also got some loose areolar tissue, and then your pericranium. And then you've got your middle meningeal artery, and then you've got your dura mater, your emissary veins or your bridging veins, and your arachnoid mater, then your cerebral arteries, and then your pia mater. So with each level here, they correspond to a different type of hemorrhage. So with your middle meningeal artery, that corresponds to your epidural or your extradural, and your emissary veins, that corresponds to your subdural, that's under the dura itself. And then you've got your subarachnoid, which is under the arachnoid, your cerebral arteries. This is from superficial to deep. Just also keep in mind with the emissary veins, they're also in the danger area connected to your cavernous sinus. So you probably don't want to, any skin infections around your triangle area of your face can also correspond to like brain abscesses or any infections. Okay, so moving on to your extradural hemorrhage. The location is essentially between your dura and your skull. So it's still within the limits of your suture lines. So as a result of that, you have a corresponding picture in your CT. So I'll go into that later. But it's essentially the rupture of your middle meningeal artery. Your middle meningeal artery is found in your pterion, which is like around your temporal region. And it's generally due to a blunt force, so like a cricket ball. Someone not wearing the helmet can get an extradural hemorrhage. So head injury causing loss of consciousness, and then you have a lucid interval, and then you have a coma. The reason why you have your loss of consciousness, first of all, is because that's sort of the initial trauma which also knocks you out. And then your lucid interval is like you get better straight away, that's fine. But in that meantime, between your lucid interval to your coma, you've got that blood leaking. And that leaking, eventually your brain cannot compensate anymore, and then that's when you fall into a coma. So during that lucid interval, it's very dangerous. It's really important to get someone to hospital. And any blunt trauma to the head or any head strike, you want to rule out an extradural. This is why they need to go into hospital for monitoring for a few hours before they can go home. So in terms of a CT, you have a biconvex or a lens-shaped bleed. And the reason why you have that is because it's still limited by your suture lines, as I mentioned before. And because of that, that bulges and that also has a greater effect on your ICP. So this is why your extradural hemorrhages are much, much more acute than, say, your subdural, where it can sort of spread across the whole brain, across the suture lines. In terms of your raised ICP, this is triad called Cushing's triad, where you have a decrease in three things. So you have bradycardia, decrease in your heart rate. You've got respiratory depression, decrease in your respiratory rate, and you've also got systemic hypertension. Sorry. So two things go down and one thing goes up. So your systemic hypertension. In terms of management of your extradural hemorrhages, generally it can be conservative if it's very, very minor, but you still need to go into hospital to get it checked out. And then your management would be to remove the clot or remove the hematoma. And if the artery is still bleeding, you want to coagulate it. Okay. So as I mentioned before, this is your middle meningeal artery. And also with age, your dura sticks more tightly to your skull. So when you get older, you generally don't get extradural hemorrhages. It's only in young people, say people in their 20s. So if you were to characterize someone, it would be a 20-year-old male playing cricket or something, a high impact sport and a head strike. Okay. So moving on to your subdural hemorrhage. So with your subdural hemorrhage, you've got the bleed between your dura and your arachnoid. In terms of the location, it's your bridging veins, your emissary veins, which sort of bridge the gap. And your presentation of a person who gets a subdural hemorrhage would be an elderly person, an alcoholic, or like a baby. The reason why you have that is because you've got, your skull is like a box and your brain is essentially this soft jelly-like material inside. So anything that shrinks your brain, such as alcohol or with age, like an elderly person, that shrinks the brain, then you put more tension on your emissary veins. Or if you're a baby and your brain's still underdeveloped and still growing, any shearing forces can give you a subdural hemorrhage. That's why they say never shake a baby, because this is why you can get subdural hemorrhages. And because it's, as I said before, the blood can leak very, very slowly. So it can be a gradual deterioration of your conscious state, maybe over a period of weeks or maybe a month. And then you can also have some dilated pupils as well, along with your presentation. In terms of your presentation as well, generally trauma is your most common cause, a head strike too. On CT, you see a crescentic or a sickle-shaped bleed. So as you can see, it's sickle shaped. And compared to the last one on a CT, that was white because it's very acute. In this case, the bleeding is probably quite old, so that's why the CT probably comes up with a dark bleed. Your management would be decompression. So if it's an acute bleed, you want to do a craniotomy and get the blood out. Whereas if it's a chronic, you want to do burr holes where sort of the blood can slowly leak out and over a period of time. Okay. So these is like your at-risk group, old people and young people. Moving on to subarachnoid hemorrhages. So your subarachnoid hemorrhage is between your arachnoid and your pia. And here you have the rupture of your berry aneurysm, which is most common. Just keep in mind as well that your berry aneurysms are associated with the kidney condition. Do you know which kidney condition? Yeah, nice. So PCKDs are linked with your berry aneurysms. I think also linked with some mitral regurg too. And also some AV malformations. So essentially it's your arteriovenous malformations, and you can have them anywhere in your brain, in your gut. It can be in your skin, so it can be anywhere. And essentially if that breaks, so it's a congenital genetic predisposed thing, so you can't do much about it apart from monitor it if you have an AVM. So in terms of presentation of subarachnoids, you have a sentinel leak. So the warning leak is sort of like a headache that you get maybe a few weeks beforehand, and then you have a sudden thunderclap headache where people say is the worst headache of their whole life. A lady on Europe told me last year that it was like someone like came up behind her and hit her on the head with a baseball bat. That was sort of how strong and how bad that headache can be. And after that, you have your signs of meningism. So your three signs of meningism generally is your photophobia and your neck stiffness and then your headache. So that's sort of your triad to ask for meningism. And also meningism can be associated with your infection. So don't forget to cover those as well during your OSCE histories. So generally your investigation again is your CT, non-contrast CT, and if that is negative and you're still highly suspicious of subarachnoid, you can do a lumbar puncture, as I mentioned before. You want to look for xanthochromia. So for management of a subarachnoid hemorrhage, you can do a clip or a coil. So essentially you can send in a coil through your arteries and essentially fill the aneurysm itself with the coil so it stops bleeding, or you can put a clip on it from the outside. And your management for vasospasm for subarachnoid hemorrhages is calcium channel blockers and triple H therapy. So what this means is that once you bleed, your vessels are very irritated, and then this sort of triggers a response where you have caspase and calcium being released, and that triggers your arteries to vasospasm and constrict. And you don't want that because that constriction can lead to sort of like an ischemic picture and no blood flow goes to the brain. So you want to stop that by giving them calcium channel blockers, such as nimodipine, and you also want to do triple therapy where you keep the blood pressure up, so blood can go up because it's traveling against the flow, against gravity. You also want to keep them in a hypovolemic state, so you can give them some crystalloids or some fluid surplus. And you also want to hemodilute their blood too, so that's also assisted by giving them, say, crystalloids or colloids. Okay. Oh, and this is just a picture of normal CSF and xanthochromia. So it's very subtle, that difference in color. Okay, just two cases. 80-year-old Daphne brought in by her neighbors because she has become increasingly confused after falling and hitting her head while gardening 3 weeks ago. And you've got Rodriguez, his head in the head with a baseball, collapsed to the ground unconscious for 5 minutes, then recovers. 3 hours later, he becomes disorientated and loses consciousness on his way to hospital via ambulance. Okay, what do you think the two are? First one would be Subdural, nice, and yeah, wonderful. So just really know your stereotypical picture and what sort of patients and what age group presents with certain conditions. Okay, cool. So moving on to comas and syncope. So just a brief break, just to give you guys a bit of a change. What if I give you 1 minute and you guys write out any differentials you have, or think about differentials that you have for someone who has a coma or a syncope? Okay, so that's roughly a minute. So what differentials do you guys sort of have? Basal vagal. Nice. That's probably your most common. So that's really good. Nice. Yeah. Yeah. Good.
Like neuro stuff.
Yeah. So your strokes. Yeah. Nice. Yeah. So that's good. So I covered your cardio and your blood pressure ones, and then also your neuro ones. Do you guys have any other systems that you have in mind? Yeah. Good. Yeah. So hypoglycemia can also give you coma and syncope. Good. What about on a Friday night or Saturday night at ED? What's a very common presentation? Alcohol. So intoxication is a big one as well. Good. And then just trauma as well, generally. Good. So this is sort of like a nice summary of comas. So coma for coma. So you can have your CO2 narcosis, so just overload of CO2. So coming through type 2 respiratory failure where you can't get the CO2 out. And you can also have a low O2 as well. So it's things like your COPD, your asthma, or if you have Guillain-Barré syndrome, and that's your neuroascending paralysis, and that paralyzes your diaphragm, that can also give you CO2 narcosis, and also just respiratory depression. Overdose, such as alcohol, opiates, benzos, antidepressants, can also give you comas, put you into coma. Metabolic hypoglycemia, as you said, hypernatremia. Very high uremia levels can also put you into coma, such as CKD. Hypothyroid and adrenal failure, so Addison's disease as well. So if you have a low NA and a high K+, someone who's got really vague symptoms, that can point you in the direction of Addison's. So it's notoriously hard to pick up. Okay, so apoplexy as well, which is sort of like just your trauma essentially. So stroke, head trauma, encephalitis, epilepsy, increased intracranial pressure. There's a lot more as well, and I'll put this PowerPoint up on afterwards to upload. But there's also other things, other acronyms that you can use. There's one called pass out, which links quite nicely for your syncope differentials too. So management for coma, first of all, you want to do your doctor's ABC because they might not be breathing. So you want to make sure everything, there's no danger. The patient can be quite violent if they're on alcohol or intoxicated. And obviously doing this safely. And immobilize the C-spine, potentially if it's a trauma case. You want to give them high flow oxygen, nasal prongs, 4 liters. And then you want to prepare them for IV fluid bolus if need be. So 2 large bore IV cannulas, 16 gauge, and start fluids.
Sorry, just for this
Yeah.
type of word, is that differentials between coma?
Sorry, coma. So syncope is a bit different because you've got more your arrhythmias coming in. So it's sort of like a witness for someone who might be previously well collapsing, whereas coma is someone who just unconscious that you find on the ground. There's like overlaps, I agree, but I guess you might have a bit more differentials for syncope. Okay, so management, first aid generally, and examination. So you want to do the vitals and blood sugar levels because hypoglycemia is a very easily correctable condition, and it's also a life-threatening one. So you can give them like dextrose like very quickly within a few minutes and save their lives. You want to examine the head for any trauma, check their pupils for any signs of like head strike or pupillary defects. Cyanosis, if they've got DKA, they may have a fruity ketotic smell to their breath. And they might have bitten their tongue too, so it might give you signs of whether it's a epilepsy or like a seizure. So whether it's at the back of their tongue or also at the front of their tongue. The peripheries may have a metabolic flap if it's something like CKD or hepatic encephalopathy. Rashes, it could be anaphylaxis as well, so you want to check for any sites of any potential angioedema. Injection sites too, if it's like intoxication, if they've got track marks. Chest, check for murmurs. Probably not that important at this point in time, but I guess it can be one of your differentials. Flail chest as well, such as trauma or like pneumothoraxes. GIT melena masses, just bleeds. So that can be your hypovolemia, putting you into a coma. Investigations, you really want to do a whole gambit of them just to, if you don't know any history to this person. So you can do FPEs, your UECs, LFTs just for baseline. And then you also don't have to do your CRPs for any signs of infectious markers, toxicology screen, urine screen if possible, septic screen too, and maybe an ECG. If it's a trauma case, you might want to do CT or MRI brain too. Okay. So you want to manage your underlying cause. So like I said, there's some very manageable ones like hypoglycemia. You can give them just dextro straight away. If it's an opioid overdose, you can give them naloxone, which is a opioid antagonist. And then you can give them alcohol withdrawal. You can give them benzodiazepine because that can also trigger a seizure. And you want to give them thiamine, vitamin B1 to replace that. So if they're also hypoglycemic, make sure you give them thiamine first before you give them the glucose because that can cause an imbalance. And okay, so with your raised ICP, you can also tilt the bed or put them on mannitol, a diuretic, and seizures, you can give them lorazepam. So just depending on what it is, you give them whatever you need. With your GCS, it's really important to know your separate individual criteria for GCS. So with your eyes, there's 4 things. For speaking, there's 5 things. And for motor, there's 6 things. Remember 4, 5, 6, and that adds up nicely to your GCS. Do you guys know this? If you guys know, I can speed through. Okay, so just make sure that you know your GCS really well because they can give you a scenario. You have to calculate your GCS. So that can definitely come up. This is sort of which I like, which will sort of shows you what they're doing at each point. I guess the most important thing to remember is that, well, the one thing that's quite different to remember in the GCS scale in the beginning is the difference between decerebrate and decorticate in your GCS, in your calculating your motor part, so 2 and 3. So in terms of decorticate, what I was told is that decorticate is your flexion, and that's still coming from your cortex of your brain. So at that part, you're still more aware than if you were decerebrate where you're extending. So when you're extending to pain, that's quite a very, very late sign because like primitively, I was told that animals, when they're trying to get away from things, they've got forelimbs, they extend and they try and push themselves away. So decorticate's your flexion, and decerebrate, where it's back to your cerebellum and your very primitive parts of your brain, that's when you extend. Okay. Just remember toast as a GCS of 3. So the lowest you can give is 3. Yes. Okay. So if you guys remember the breakdown. So if he opens his eyes when you speak to him, what voice out of 4, what is that? Yeah, so that's 3, good. And answers inappropriately to your question. I think there's a step between confusion and inappropriate, actually. 4, yeah. And withdraws to pain. So I put 3 for voice, actually. So just scroll back. So 3 for the eyes, because he responds to verbal commands. 3 for verbal response, because it's inappropriate, whereas as opposed to sounds and confused. So I guess this is also very dependent on wording. And then he withdraws from pain. So 4, 3, and 3. So that's sort of, that gives you a GCS of 10. Okay. So it's really important to remember GCS 3 and 8. So I said 3 inanimate objects have a GCS of 3. So that's the lowest you can go. And GCS of 8, lower than 8, you want to intubate. So at this point, they're probably not able to look after their own airway. So you probably need to do invasive measures to make sure that the airway is still sustained. So that's your 2 important numbers, 3 and 8. Okay, so moving on to spinal tracts briefly. So in terms of your upper motor neuron and lower motor neurons, I guess this is also a bit of a revision. So upper motor neuron is anything that is above your anterior horn. So this is sort of your lower limb, your lower motor neuron going out, and then you've also got, say, your muscle here contracting. And then this sort of synapses at your anterior horn, and then it sends a tract all the way up to your brain. So anything above the anterior horn here is an upper motor neuron lesion. So that's your motor cortex, your brainstem, and your spinal cord. And anything below your anterior horn, anything down here, would be your lower motor neuron. So your nerve plexus, your peripheral nerves, your nerve roots. So with your upper motor neurons, everything is up. That's how I remember it. So you've got your hypertonia, so your increased tone, because you don't have any inhibitory signals coming down from your brain, and you've also got your lower motor neuron just firing away by itself, so that gives you increased tone. You've got clonus, so you've got very large movements triggered by a reflex, because again, you don't have your inhibitory signals coming down. You've also got hyperreflexia, so that also explains it, and your Babinski sign comes back where you have fanning of the toes, so that goes, the toes go up too. And then you've got no atrophy because you still have some electrical signals going to your muscles, so that's why you don't have as much atrophy compared to your lower motor neuron. So if you compare it, you've got hypotonia, you've got fasciculation, so these small movements, as opposed to your large movements of upper motor neuron, and you've got decreased reflexes, and you've got atrophy of your muscle. Cool. So this is your overview, and this is a picture that I found from a past PowerPoint, which I thought was quite a good way of representing the tracks going up to your brain. So if you want to remember it in such a way, you've got your motor in red, and then you've got your sensory in the three below. So with your motor, you've got your corticospinal stuff going from your brain, your cortex, to your spine. So it's going downwards. It's a motor going down. So it's a motor function, and it decussates at your lateral brainstem before it goes down again. So it decussates quite early at the top. With your dorsal column, you've got vibration, proprioception, and fine touch. So that's your orange up here. And it also decussates quite early at your brainstem. And it's your medial lemniscus, at your medial lemniscus. So it's down here. With your spinal cerebella, you've got, it's generally for proprioception, you've got your ventral and your dorsal parts. The dorsal part doesn't decussate as much. Your dorsal part doesn't decussate, and your ventral one does, but just remember that it doesn't decussate. So it goes up like this. With your spinothalamic, that's your pain and temperature on your lateral side. Then you've got your crude touch and your pressure at the anterior side. So that decussates 1 to 2 levels before exiting your spinal cord. Okay. So that's sort of a decussation right at that level, at levels 1 to 2 here. Okay. So if you were to translate that sort of to this picture, to sort of someone who's facing you guys. So this is the back of the person, so the dorsal part, that's all of your sensory and your proprioception. And then you've got your motor parts here on the inside. And just remember that you've got your cervical, thoracic, lumbar, sacral region. So you've got your cervical parts more on the inside, and then you've got your thoracic parts more on the outside again, then lumbar on the outside, and then sacral on the outside. So if you can sort of see, it's sort of your most top part of your body is at the deepest part of your spinal cord. Okay, and then here you've got your spinal cerebella for proprioception on the sides. You've also got your spinothalamic, your cold and pain, so your temperature and pain on the sides as well, your anterior lateral side. Okay, so that's sort of like a general overview. And then your brainstem rules of 4s. Have you guys heard of this? It was probably from last year as well. But just a quick overview again, you've got 4 midline structures beginning with M, so that's over here on the right, and then 4 side structures with S on the bottom here. And then you've got 4 cranial nerves, 1, 2, 3, 4 above the pons, 5, 6, 7, 8 at the pons, 9, 10, and 12 below the pons. And then you've got 4 midline motor nuclei, which divide equally into 12, so that's your 3, 4, 6, and 12. So if you guys want to go over this again, I really recommend Life in the Fast Lane. It's got a really good resource in terms of breaking down these and giving you a few good cases. So just going through your midline structures quickly, you've got your motor pathways I mentioned before, your corticospinal. As you can sort of see, it's sort of quite close to the middle part of your spinal cord. And you've got your medial lemniscus, your vibration and proprioception. So I guess this is your spinal cord, you can't really visualize it, but that's more so at the top, near your cerebellum level. Oh, sorry. And then you've also got your medial longitudinal fasciculus, which is sort of corresponding your vision between your 2 eyes. So that's sort of your internuclear ophthalmoplegia, which is when your eyes sort of, when you look to the left, your cranial nerve 4 and 6 don't really work together, and you sort of get like a palsy on one side. You have 3, 4, 6, and 12. Okay, your side structures, if you have a damage to the area, it's also called lateral medullary syndrome. It's with your spinal cerebellar tract, so your proprioception, your spinothalamic tract, on your contralateral side, because it's already decussated down here, and then your sympathetics on the same side, your ipsilateral sympathetics, say near your face, and then your sensory nucleus of cranial nerve 5. on the same side too. Okay. Okay. So during Melbourne Marathon, Sarah is jostled by a spiteful runner and falls back first onto the road on top of an unfortunately placed nail. So now she's unable to feel pain or heat on the left side of her leg, and she also can't move and she can't feel the tuning fork's vibration on her right. What does she have? Yes. Okay. Nice. Do you guys sort of get why it's bounce a card? And okay. So I'll go through it. Yeah. Yeah. So weakness on the same side of the body, and so she can't move. So that's sort of hinting at the weakness, and she's also got loss of proprioception on the right-hand side because that hasn't decussated yet. And then because she can't feel pain or heat on the left-hand side, it's because that's already decussated at that level, and that's affected the spinothalamic tract, which is on the opposite side. So brown saccade is essentially a hemisection to your spinal cord where half of your spinal cord is affected. And essentially, you can think about it as everything is ipsilateral apart from your spinothalamic, because that's the only thing that crosses early, because everything else crosses quite late. Okay. So this is like a picture trying to show you brown saccades. And if you were to go through your different types of sections, you've got your whole cord section where essentially might be a motor vehicle accident or like just blunt trauma where you essentially have a whole decussation of your spinal cord. So obviously that means you lose all of your tracts at that level, and everything is lower motor neuron below, and everything is upper motor neuron. Sorry, everything is upper motor neuron below that lesion, apart from that level itself where it's your lower motor neuron. So your hemisection, otherwise known as your brown saccade, is where you have a partial hemisection of your cord, so half of your cord is gone, and that means your ipsilateral, the same side of your dorsal column of your vibration, proprioception is still okay. The same side of your corticospinal, your motor in that case is affected, and then your contralateral spinothalamic, your pain and temperature is affected because that's crossed. So with your central cord, there's this thing called a shawl distribution. So if you guys remember to this picture here, you've got your cervical at the top, and then you've got your lumbar and your sacral further down in your spinal cord. So if you have something that's growing in here in your spinal cord centrally, your cervical region first. That sort of makes it. Yeah. So, and when it grows and it expands, it sort of grows down in a shawl-like distribution. So it sort of means like you've got your cervical bits which are affected first, and then your shoulders, so a bit like a shawl. I think that's what you're getting at. And then, so it affects your upper limbs first before your lower limbs. And things that can affect your central cord can be things like syringomelia, which is sort of like this cystic space within your spinal cord. And then it can be congenital, it can also be acquired, so it can be like an infection, or it can be from stroke, or it can be from a congenital malformation. It just sort of grows, it just erodes away your spinal cord, and it happens from the inside out. You also have some urinary retention as well if you have a central cord section. If it's a posterior column section, that would just be here, as I mentioned before, so that would be all of your dorsal columns, so proprioception and vibration. Yeah. I'm not sure, sorry. Probably have to look that up. Yeah. Okay. So moving on to peripheral neuropathy. One way of remembering your most common peripheral neuropathies is DEBUT, D-E-B-U-T. So diabetes is very common. They can also give you peripheral neuropathy in your glove and stocking distribution. Ethanol, long-term ethanol use can also give you peripheral neuropathy. Whereas B12 deficiency, so vegetarians have to be careful to keep their B12 up. And uremia, so things like CKD can also give you peripheral neuropathy. And thyroid, hypothyroidism in particular, can give you peripheral neuropathy. There are other ones, such as degenerative ones. There's this thing called Friedreich's ataxia. It's a congenital syndrome where you also have an increased risk of getting not just peripheral neuropathy, but also like diabetes and congenital heart problems. Charcot-Marie-Tooth is also another inherited condition where sort of your muscle sort of wastes away by itself. Motor neuron disease and multiple sclerosis. In terms of inflammatory conditions, infections, shingles, HIV, and also Guillain-Barré, which is also an ascending paralysis. And also autoimmune conditions can affect your peripheral nerves. Toxic ones would include alcohol, drugs, statins, phenytones, anti-epileptics. Chemotherapy is very potent in terms of affecting your nerves, and isoniazid, which is one of your TB drugs. And also, that should be a V. So heavy metals can also affect the peripheral nerves. Deficiencies in vitamin B12 and vitamin A, B1, your thiamine, and vitamin E can also affect it. I guess vitamin B12 is your most common one, most commonly seen in the community. And in terms of metabolic, you've got your diabetes, chronic kidney disease, amyloid, so protein plaques in your nerves, and also hypothyroidism. Okay, so if you were to match the condition, glove and stocking, mononeuropathy, say of your quadriceps, autonomic neuropathy as well, so gastroparesis and like poor gut function. What condition would that be? Yeah. Oh, okay, diabetes. Yeah. So dorsal column, vibration for proprioception, a certain vitamin. Yeah, vitamin B12. So that can happen. In this day and age, you generally don't see it very commonly because people are quite well aware of the sufficiencies they can get. But I did see it in my GP practice. So from a vegetarian who needed vitamin B12 injections because it got so bad. So yeah, vitamin B12 for dorsal column. Good. Inherited progressively worsening coordination. So either your Friedreich's or your Mary-Charcot. Friedreich's, yeah, Friedreich's ataxia, good. And your inherited condition, foot drop, pes cavus, which means you sort of have like arched foot here, and then claw toes, champagne bottle legs, Charcot-Marie-Tooth, yeah. And then your post-infectious diarrhea, sensory, and then your motor and ascending paralysis. Yeah, GPS, wonderful. And then GPS can get pretty bad that you might need to go on a respirator as well sometimes. Mental admission. Okay, so going through MS, conscious of time, do you guys want me to speed through the rest? Yeah? Okay, just don't want to keep you too long. Okay, so multiple sclerosis, going through the etiology, autoimmune destruction of your myelin sheath. So think of your myelin as this protective thing around your nerves. It sort of cushions and it sort of increases the speed where electrical impulses travel through. So when you destroy your myelin sheath, you no longer have that, you get demyelination. And then that demyelination can lead to destabilization, and that can also lead to degeneration of your nerves. So this is like a chronic condition that sort of just gets worse and worse. Your diagnosis is that it has to be disseminated in space and time. So what this means is that you can have these changes in your nerves in different parts of your body, and also has to be separated by time, so like over a period of a few months or years. And you can do this from clinical history or through an MRI scan. Risk factors would be females between the ages of 15 to 45, family history, and smoking. And apparently they think there's a role of vitamin D in this picture as well. So if you're far from the equator, you're at increased risk of multiple sclerosis. So there we go. So investigation, you want to do an MRI if you want to diagnose the dissemination in space and time. So you might see some hyperdense plaques. A buzzword you might hear for multiple sclerosis would be an oligoclonal bands on CSF, on electrophoresis. So you only do a lumbar puncture if your MRI comes up negative, and you want to look for these bands. And because it's an autoimmune condition, this is why you have these oligoclonal bands. So the same protein coming up, which is probably attacking your myelin. Your presentation is that it's a relapsing remitting condition, and you might have things such as depression or fatigue. You might have sensory changes such as the MIT sign. So this is a sign where you have the shock that you feel when you flex your head. So it might be like irritation to your nerve itself. Also trigeminal neuralgia or paresthesia. You might get hyperreflexia, autonomic instability, because it's affecting your upper motor neurons more so. And then your vision as well, so your optic neuritis, which can come in the form of your relative afferent pupillary defect, or also known as your Marcus Gunn pupil, and your internuclear ophthalmoplegia. So just run through these two conditions briefly under your optic neuritis. So RAPD is when you have your optic nerve is not working very well. So for example, if my right optic nerve has optic neuritis, I might get RAPD. So in this sense, my optic nerve is not receiving light very well, but it still receives a bit of it. So if I get some light, my pupil will constrict, but probably not as much. And then if I shine light on my left eye, which is completely normal, I will have a normal pupillary constriction because this is a normal optic nerve, and it also tells my right eye through my brain that it should constrict equally. So it's constricted. But when you do the swinging pen torch sign, where you swing from the normal left eye to the abnormal right eye, your right eye only gets the light. So it still constricts, but it's not receiving as well as the left eye. So the constriction is not as much. So it looks like it dilates a little bit. So it's still constricted, but it sort of looks like it's dilating. So this is why it's a relative afferent pupillary defect. In terms of your internuclear ophthalmoplegia, this is your eyes not following or tracking very well. So if my cranium, like I said before, if I'm looking to the left, it needs coordination between my left lateral rectus, yes, and my right medial rectus to work together. So it needs your cranial nerves 4 and 6 to work together because the pathway is not working very well and the nerves aren't working well. This is why you have like a bit of a pause and your eyes aren't in line. Okay, so for management, it's a variable disease course, and like any other chronic condition, autoimmune mediated, you need your immunomodulators and your immunosuppressants. So you need your immunomodulators like your interferon beta to suppress it, and also your immunosuppressants like steroids to suppress it down during an acute attack. And for symptomatic relief, such as extradural neuralgia or your pain, you can take TCAs or NSAIDs or even baclofen. Okay. Sorry, I put the answer up already. I didn't. So if you want to go through it quickly, she's got a 4-day history of impaired vision. So this is her acuity sort of affected, and objects look distant and dull to the right. So that means her right eye is affected. She has a bit of a headache, which is worsened by moving her eyes as well. Visual acuity is reduced, and but from the outside, her eye looks completely normal. But there is swelling of the right optic disc. People on the right reacts poorly when light is shone in the right eye, but well when it's shone in the left. So there's RAPD as well, and it's in the right eye. Yeah, and the left eye is normal. So sorry, I put the answer up already, but it's optic neuritis, and you've got a few signs with that. So you've got your RAPD, your pain on eye movements, oh gosh, and then your impaired color vision as well. So you want to use your Ishihara color plates as well to check for optic neuritis, and your pale optic disc. Okay, so I think headaches and then inflammation infections is the last part. So in terms of your headaches, you've got your primary and your secondary headaches. So what primary means is that your headache doesn't really have a source, or like we don't really have a reason why you have your headache, and that's your migraine cluster and tension. Trigeminal neuralgia is a bit of a special headache because you do know the cause. It's to do with your cranial nerve 5, but it's a cranial neuralgia. So it's sort of sitting between secondary and primary. And in secondary, sort of like your dangerous ones, your meningitis, sinusitis not so much, but your temporal arteritis, your raised ICP, stroke, hemorrhage are all dangerous. And don't forget your rebound headache when you're asking your headache questions. If you're taking Panadol, if you're taking caffeine, how long have you been taking it for? Did you stop it suddenly? So that can also be a cause of headache. Okay, so headache types, you really want to localize where it is. So you've got your band-like headache for your tension, you've got your unilateral one for your migraine, you've got your cluster one, which is retroorbital, periorbital around the eye. That's really, really painful. Then your sinusitis is more your facial pain as opposed to your head. Okay, and also you want to characterize the headache in terms of time course. So if it's an acute and recurrent headache, such as migraines, it sort of looks like this picture where it gets really, really bad intensely and acutely, but then you have periods of where you don't really get that pain. Chronic non-progressive is sort of like your tension, so you sort of always have that headache there slightly. The one that you worry about is your chronic progressive, where you have tumors or like an abscess or increased intracranial pressure, but it's sort of like getting worse and worse and worse, where you can sort of eventually culminate in like morning vomiting and like headaches in the morning. Okay, so moving on to your tension headache, Metacomics is very, very good to look at pictures, and it sort of ties in your headache pictures very nicely. So Metacomics is your tension headache, so it's generally your most common cause of headache in adults and the general public, and it's a tension band-like headache, and it can be bilateral, can last for hours or days. Your cluster headache is generally seen in males, and it's around your eye, and it can be intensely painful, and it's generally in clusters. So it happens, say, a few times a day for a few days of this month, and then you don't get it again, say, for many, many months or until next year. So it happens in a cluster. And you also use O2 as a prophylaxis with verapamil. Okay, and then your migraine headache, this is the headache which you most commonly see presenting to ED, and it's generally, you generally have a prodrome first of all, and then you have an aura, as you can sort of see, and then you have photophobia and a severe unilateral throbbing headache that lasts for roughly 4 hours to 72 hours. You also have some nausea, vomiting, or hemiparesis can get pretty bad, and then you can also have a postdrome where you're quite tired and lethargic. And this is your triggers for migraine headaches. It's a lot. So food, hydration, the pill, smells, seeing things, hearing things can all trigger your migraine headaches. You may need to do an MRI to rule out other causes, because if you can get nausea, vomiting, hemiparesis, and really bad headache, that might make you think meningism. Okay, so this is your primary headache presentation. So you've got your tension, your cluster, and your migraines. Sort of went through this already, but just keep in mind that cluster is mostly male, migraines mostly female. And probably go through your types of visual auras you can get, such as blind spots or shimmering lights or colors. Okay. So with your management, with your tension ones, you can just probably manage at home if it's not too bad. NSAIDs, paracetamol. You can do amitriptyline or beta blocks for prophylaxis. For your cluster headaches, they have to come into ED, I guess, for high flow oxygen and a triptan. It's a serotonin agonist, and it's very effective at treating your cluster and migraine headaches, but it's not very good as a prophylaxis or as a cure. So if you have these headaches, you sort of just have them chronically. For your migraines, you can treat them acutely with paracetamol, NSAIDs, antiemetics, or triptans. If it's chronic, you can do prophylaxis. So you can use medications. If you're using medications more than twice a week, you probably want to be in beta blockers or tricyclics or antiepileptics to manage your chronic migraines. In terms of prevention, you want to identify your trigger if possible and avoid them. So regular sleep, meals, and exercise will help, and avoid stress. Apparently magnesium can also help with your migraines, and you want to take a headache diary to sort of like rule out when you get your headaches and sort of work out, if you can, what triggers your headache. So ruling out secondary headaches, you've got your life-threatening ones, which are really important. So your SAH, or your intracranial hemorrhage, so that's a sudden severe thunderclap headache. Your raised ICP, this can be worse in the morning, projectile vomiting, exacerbated by cough, sneeze, or straining. Intracranial lesions, so that's your focal neural deficits and your weakness and sensory changes. If it's like a cancer, it can be a primary cancer or a metastasizing cancer. You want to ask about B symptoms, so your fatigue, your weight loss, your night sweats. Infective causes, so you might have a stiff neck, photophobia, rash, fever, vomiting, or confusion. Okay, non-life-threatening but still quite serious. Temporal arteritis, so this is your headache where you have unilateral temporal headache and you have jaw claudication. So chewing on like things can hurt, and you can also have tenderness in your temporal artery, so on palpation that can hurt. You have a sky-high ESR, which is more than 50, and you want to put them on high-dose spread straight away. Don't wait to biopsy. That can wait. And you can also get scalp tenderness too, like combing your hair can be painful. This is often associated with your polymyalgia rheumatica, and where you have girdle and hip girdle, shoulder girdle pain or weakness. Trigeminal neuralgia, this is your one-sided pain, so your 60-year-old episodic severe pain shooting from side of the mouth to the ipsilateral ear or face, ear or eye, sorry, and you treat them with carbamazepine. Okay, other secondary headaches, so withdrawal headaches from if you take caffeine, paracetamol, and you stop taking it. It can be referred pain from your jaw. It can be sinusitis, to ask about respiratory history, or it can be a seizure prodrome as well. But you can probably tailor this in your history in terms of age group. So if it's someone in their 80s who doesn't have a epilepsy history, you probably don't need to ask too much about their seizure prodrome. And also benign intracranial hypertension, otherwise known as idiopathic intracranial hypertension. Generally seen in overweight females. It's like a daily headache, which is worse in the mornings, and you get vomiting. So you have raised intracranial hypertension, but it's generally fine, so it doesn't really affect you. Okay. 63-year-old man describes 3 months of increasing right temporal headache and scalp tenderness. He's got pain on chewing and right visual disturbance. Wonderful. Yeah. And what is your next course of action? High-dose prednisolone. Yeah. And then refer to room as well. But always make sure they go on prednisolone because they can lose their vision really quickly. Okay. Okay, occipital headache, neck stiffness, confusion, vomiting, an episode 3 weeks ago. So she's got neck stiffness, confusion, and vomiting. Vomiting probably from the raised intracranial pressure. Neck stiffness and confusion from irritation to the meninges, the blood in the meninges. Yeah, subarachnoid. Yeah. And what would you call this, the episode 3 weeks ago? Sentinel leak. Yeah. I guess with your migraines, you probably have a more prolonged, as opposed to a sudden onset. Okay, cool. So, yeah. So it's generally at the back. So it's near your in your circle villus, and it's generally like thunderclap headache to your back, so occipital region too. Yeah. Okay. So very briefly, we'll run through infections and so meningitis. You probably read this in your own time, but just know that the very young, the very old, the immunosuppressed ones, and people who have HIV are at risk. So fever, headache, neck stiffness, altered mental state. Purpuric rash and Neisseria, is it non-blanching or blanching? Non-blanching, good. So one picture you commonly see is like people using like a glass cup that's see-through, like a Pyrex cup. So like you can apply pressure and you can see that it's non-blanching and it's purpuric. Cool, and photophobia too, so meninges and signs. And what 2 other signs can you do clinically, like on the bedside? Yeah, and what's that?
Well, clinics is when they can't like extend completely right. So
Yeah. Yeah. Good. Very nice. So that's your Koenigs and your Brzezinski's. And this is clinical signs you can look for. Just keep in mind that it's actually, so the reason why they do this is because the meninges are irritated and your nerve roots themselves are irritated. So when you stretch it, they sort of stretch as well. They want to go along with it. Just know that for old people and babies, they're not very specific signs because I guess babies, they're quite floppy. And I'm not too sure about old people, but generally it's a good sign for adults. So for bacterial, these are your most common bacterial ones. Probably know strep, Neisseria, and Haemophilus. Those are the most common ones in adults. And your viral ones can be your HSV, Coxsackie, or Echo. Listeria is, you can't see that, but generally also neonates. So your buzzwords for each of them, Streptococcus pneumoniae is your number 1 cause in adults. Neisseria, teenagers, young adults, plus your purpuric non-blanching rash. Haemophilus, it used to be the number 1 cause until the vaccination came out. So unvaccinated people are at risk of Haemophilus influenzae. So if like a migrant comes with like meningitis signs, you want to be suspicious of Haemophilus influenzae. Listeria, elderly, neonates, and HIV and pregnant people at risk. Neonatal meningitis, this is probably more 4th year, but group B strep and E. coli are more common than your strep and Neisseria. And in HIV, because they're immunocompromised, they can have very atypical meningitises, I guess. So your TB, so TB generally won't grow in culture very well in CSF. You can also have your fungal infection, so your cryptococci, and your buzzword for that is your Indian ink stain, which is used to stain your fungal spores. And also syphilis too. Okay, so investigations, do a lumbar puncture because you want to grow the culture and diagnose and give them antibiotics ASAP. CT, if you're not sure if they've got a raised ICP because you don't want to cause them a herniation. Give empirical antibiotics depending on age group. So in this case for adults, it's your IV Keftrax and your dexamethasone. If you have suspicion for Listeria or Neisseria, if you've got purpuric rash, or if they're like a pregnant lady, or if they're like some immunosuppressed, you want to cover Listeria too. So you want to give them Benpen. If it's strep or staph suspicion of that, you can give them IV vancomycin. But also check ETG as well. Blood cultures and also antibiotic tailoring. So what this means is that you want to grow the culture of what bug it is, and once you know what bug it is, you can tailor off your empirical and just give them the one antibiotic which they need. Okay, so going to your CSF sample very quickly. With your bacterial, what will it look like? Cloudy. Cloudy, turbid, wonderful. Word for word. Cells, what sort of cells will you get? Oh. Yeah, polymorphs, neutrophils, good. Protein will be normal high, because you've got your polymorphs. Yeah, and then your glucose levels will be low, good. Okay, viral will be, yeah, and cells will be lymphocytes. It can be neutrophils during the first few days as well, to keep that in mind. Protein will be normal, yeah. Glucose, normal, yeah, good. With your TB or your fungal ones, it will be cloudy, yeah. Cells will be lymphocytes plus, because your body can't, your neutrophils aren't enough to, it's like a chronic thing, so you've got your body producing lymphocytes to it. Protein will be probably plus as well. And then your glucose will be low. Good. And some people also describe it as like cobweb-like for your CSF. Okay, so encephalitis, you've got your etiology, generally HSV, EBV, or your varicella, other viruses. Just keep in mind that you can only treat herpes encephalitis, so give them IV acyclovir. Otherwise, everything else is supportive. Also know that with encephalitis, it's very similar to your meningitis, but you have your focal convulsions or your neurological deficits, because it also affects the brain itself. So you've got your meningitis, encephalitis, and you also get like a mixed meningoencephalitis too. The CT, MRI, EEG, lumbar puncture, more like ruling out than anything else, because lumbar puncture won't grow anything because it's viral. EEG, you might get seizures, but sort of like ruling out, I guess, other causes of seizures. Okay, brain abscess, very quickly, anaerobes, aerobes, gram-positive cocci. Can have a headache, fever, increased intracranial pressure, and focal neurological findings because it's located at that site. If you have a right to left shunt, so if you have a atrial septal defect, so your heart has a hole in the atrium, blood won't go directly through to your ventricles, your left side of your heart, sorry, your right side of your heart going to your lungs. So if you don't have that shunt, you might get a lung abscess, but because it's bypassed and it's gone straight through to your left atrium, down to your left ventricle, up through your aorta to your carotids, going to your brain, this is how you get a brain abscess. Also, your paranasal sinusitis, so if you have infection in your emissary veins, can also go to your brain. Trauma, immunosuppressions can also give you brain abscesses. CT and MRI is a general go-to to locate the abscess. I don't think faculty will be mean enough to give you a scan to interpret, but probably like really obvious ones like subdural, subarachnoid, know how to recognize them. Maybe an abscess as well. I guess your buzzword for brain abscess would be you have an abscess in your corticomedullary junction, and you have a central area of necrosis where it's dark. And it's also a ring-enhancing lesion too. And it's not composed of solid tissue. So how you treat it would be your fluclox, your cefotaxime, your metro, covering all of your bases. Gram-positives, negatives, and your anaerobes. Cool. So now stuff I haven't gone over today would be your epilepsy and dementia delirium. Hopefully you can go through that in your own time, but hopefully that was helpful. And thank you very much. Okay. Yeah, sure. I can.
In one of the questions about,
Yes.
about MS, it was like a lady who also had a headache. Is that like typical for
MS?
It was like, I think it's like she got a headache when she was like moving her eyes or something.
Oh, yeah. So in that case,